Are you over 60 and taking your blood pressure medication every morning? Maybe you set it out next to your coffee. Maybe you take it the moment your feet hit the floor. Maybe you have done it that way for years because that is what your doctor told you, or because it was the easiest habit to build, or simply because morning felt like the right time to start the day with your health in order. I need you to stop and watch this before you take that pill tomorrow morning. Because what the research now tells us about when seniors take blood pressure medication and what that timing does to the body may be the most important piece of cardiovascular information you have not heard yet. And I do not mean that lightly. I'm Dr. Sandra Hollis, and I have spent the last 20 years working with patients over 60 on exactly these kinds of questions. Not just what medication, not just what dose, but when. Because the when, it turns out, changes everything in ways that most patients are never told and that most prescriptions never specify. By the end of this video, you are going to understand why morning may be the wrong time for your specific body, why the research that changed the conversation was ignored for years, what your body is doing between 2 in the morning and 10 in the morning that makes timing so critical, and what the right approach looks like for someone in your situation. And I am going to do this through real patient stories, because this is not an abstract lecture. These are people like you who made one change to when they took a pill they were already taking, and it changed what happened to them at the most critical hours of the day. Stay with me until the end, because the last thing I'm going to share is something almost nobody talks about, a morning timing mistake that is so common among seniors that I consider it one of the most overlooked cardiovascular risks in people over 60. And it has nothing to do with what medication you are on. Let me start with the biology, because if you understand what your body is doing during the night and early morning hours, everything else will make immediate sense. And I want to tell you about a man named Richard first, because his story is the reason I began looking at this issue so carefully in my own practice. Richard was 67 years old, a retired high school principal from North Carolina, organized, conscientious, and exactly the kind of patient every doctor hopes for. He had been on lisinopril for blood pressure management for 4 years. He took it every morning at 7:15 without fail, with a glass of water before breakfast. His readings during afternoon clinic visits were decent. His doctor was satisfied. Richard felt reasonably well. And then Richard had a stroke. It was a mild stroke, what neurologists call a transient ischemic attack, a brief interruption of blood flow to the brain that resolved without permanent damage, but left Richard and his family shaken in a way that no clinical description fully captures. When we reviewed everything carefully, one pattern became clear. Richard's blood pressure during the early morning hours, in the window between approximately 5 in the morning and 10 in the morning, had been running significantly higher than his afternoon readings. He had no idea. No one had ever measured it. And his morning pill, taken at 7:15, had been providing its maximum effect in the afternoon, when his pressure was already naturally lower. In the morning, when his pressure was surging, the medication was at its weakest. What Richard experienced is a consequence of something called the morning blood pressure surge, and it is one of the most important cardiovascular concepts that most patients over 60 have never heard explained clearly. Let me walk you through it precisely, because this is the foundation of everything that follows. During sleep, in most healthy people, blood pressure drops by 10 to 20% from its daytime baseline. This is called nocturnal dipping. Your body is resting, your nervous system is quieter, your blood vessels are more relaxed. Then, in the early morning hours, typically beginning around 3 or 4 in the morning and accelerating sharply between 6 and 10 in the morning, a cascade of physiological changes occurs. The body prepares to wake up and be active. Cortisol levels surge. The sympathetic nervous system activates. Hormones called catecholamines, including adrenaline and noradrenaline, begin flooding the bloodstream. Blood vessels constrict. Heart rate increases. Blood becomes slightly more prone to clotting. Platelet activity rises, and blood pressure climbs rapidly, often reaching its highest point of the entire day in that early morning window. This is not a malfunction. This is the body doing exactly what it evolved to do, preparing you to go from sleep to activity. But in people with hypertension, particularly older adults whose vascular systems have less flexibility, this morning surge can be extreme. Blood pressure that is well controlled at 2 in the afternoon can be dangerously elevated at 7 in the morning. And that morning surge is not benign. Research consistently shows that the majority of heart attacks, strokes, and sudden cardiac deaths occur during the morning hours, clustering heavily between 6 and noon. That is not a coincidence. That is the morning surge doing its most serious damage in the most vulnerable vessels. Now, here is where the timing of medication becomes so critical. Most blood pressure medications, including the ones millions of seniors take every single day, have a defined duration of action. Lisinopril, taken in the morning, reaches its peak effect within a few hours. By the time the next morning arrives, its effect has been declining for many hours. The medication is weakest precisely when the blood pressure is highest. It is as if you put the most protection on the hours when your pressure is already naturally lower, and you left the most dangerous hours with the least coverage. This is the core of what the research revealed, and the research I am referring to is substantial. A major trial called the Hygia chronotherapy trial, conducted over several years and involving thousands of hypertensive patients, found that people who took their blood pressure medication at bedtime rather than in the morning had significantly better cardiovascular outcomes. Lower rates of heart attack, lower rates of stroke, lower rates of cardiovascular death. The bedtime group also showed better nighttime blood pressure control and better suppression of the morning surge. The findings were striking enough that they began shifting the conversation in cardiology circles, though the translation to everyday prescribing practice has been slower than the evidence deserves. Let me be precise about what I am saying and what I am not saying. I am not telling you to change when you take your medication without talking to your doctor first. I am telling you that the question of when to take your blood pressure medication is a real clinical question with real evidence behind it. And if your prescriber has never raised it with you, it deserves to be part of your next appointment conversation. For some patients, the timing matters enormously. For others, specific medication types or individual circumstances mean the calculus is different. This is a conversation, not a prescription. Now let me tell you about Dorothy, because her story illustrates what morning timing can do to someone over 60 whose body is already dealing with age-related vascular changes. Dorothy was 72 years old, a retired bookkeeper from Missouri, precise by temperament, and deeply committed to doing everything her doctor recommended. She had been on amlodipine for blood pressure for 3 years, taken every morning at 8 o'clock. She was also on a statin for cholesterol. Dorothy had never had a cardiac event, and her afternoon blood pressure readings at her doctor's office had been acceptable. But Dorothy had started noticing something over the preceding months that she had trouble explaining and almost did not mention because it seemed so minor. Every morning, between waking and about 10 o'clock, she felt what she described as a pressure behind her eyes, a heaviness. Her vision felt slightly less sharp. She occasionally felt her heart beating harder than expected when she moved from bed to bathroom. By 10:30 or 11 in the morning, she generally felt fine. She assumed it was arthritis, or aging, or dehydration, or any number of things that seem easier to attribute to being 72 than to a medication she had been on for 3 years without obvious problems. What Dorothy was describing were the subtle, perceptual, and physical signatures of a morning blood pressure surge that was not being adequately controlled. Her amlodipine, taken at 8 in the morning, was providing its strongest effect in the early afternoon when her pressure was already declining naturally. In the early morning hours when her pressure was surging, the medication was providing its weakest coverage. The pressure behind her eyes, the visual heaviness, the sensation of her heart working harder, these were her body's ways of registering an elevation that no afternoon reading in a doctor's office had captured. Dorothy's cardiologist, after reviewing a home blood pressure monitoring log that Dorothy kept for 2 weeks at my suggestion, agreed to trial an evening timing for her amlodipine. Not bedtime precisely, but early evening, around 8 in the evening, 12 hours earlier in her day than her previous routine. Within 3 weeks, Dorothy reported that the morning heaviness had resolved. Her 2-week home monitoring log showed her morning readings had dropped meaningfully. Her afternoon office readings remained similar. She had not changed her medication, her dose, her diet, or anything else about her routine. Only the clock time of a single daily pill. Dorothy's experience is not universal. Not every patient will see this outcome. But Dorothy's experience is representative of a pattern I have observed repeatedly, and that the research supports more broadly. For many older adults, bedtime or evening administration of antihypertensive medication provides better coverage of the high-risk morning hours than morning administration does. Now, I want to talk about what happens to the body specifically after 60 that makes this conversation even more important for you than it might be for someone who is 45. As we age, several things happen to the cardiovascular system that change how blood pressure behaves and how medications work. First, blood vessels become stiffer. The aorta and large arteries lose some of their elasticity, which means they absorb the force of each heartbeat less efficiently. This stiffness makes the morning surge sharper and higher. Second, the autonomic nervous system, which regulates blood pressure automatically, becomes less precise in its adjustments. The counter-regulatory mechanisms that would normally moderate a morning surge become less responsive. Third, kidney function changes with age, which affects how medications are cleared from the body and how long they remain active. Fourth, seniors are more vulnerable to the effects of both high blood pressure and low blood pressure, with a narrower safe range between too high and too low. That narrower margin makes the timing of peak medication effect more consequential. What this means is that the morning surge in seniors is often more pronounced. The damage it causes accumulates more quickly against older vascular tissue, and the window of vulnerability during inadequate medication coverage is narrower and less forgiving than in younger patients. The stakes of timing are higher over 60, not lower. Let me tell you about George, because his story adds a dimension to this that I want to make sure you do not miss: the dimension of sleep and what happens to blood pressure control when sleep is disrupted. George was 69 years old, a retired electrician from Indiana, a light sleeper by nature, who had developed classic older adult sleep patterns over the past decade. He woke 2 to 3 times a night to use the bathroom, a common consequence of prostate changes in men his age. He typically fell back asleep, but his sleep was fragmented and his mornings felt unrestored. George had been on metoprolol, a beta blocker, for both blood pressure and mild heart rhythm management, taken every morning with breakfast at 7. His doctor was not particularly concerned about his blood pressure numbers, which looked reasonable at office visits. But George had started experiencing what he described as a terrifying feeling on mornings when he slept particularly poorly, a combination of racing heart, flushed face, and a sense of pressure in his chest that would take until 9 or 10 in the morning to settle. What George was experiencing on his worst sleep nights was a potentiated morning surge. Fragmented sleep, particularly in older adults, disrupts the normal nocturnal blood pressure dip. Instead of blood pressure declining by 15 or 20% during sleep, it may decline minimally or not at all. Then, on top of an already elevated nighttime baseline, the morning cortisol and catecholamine surge hits at its full amplitude. The resulting morning blood pressure can be dramatically higher than anything seen in a well-rested individual, and dramatically higher than any reading captured in a daytime doctor's office. George's situation illustrated something important. For patients whose sleep is consistently disrupted, whether from nocturia, pain, sleep apnea, anxiety, or any other cause, the morning surge can be more dangerous and more variable than for those who sleep soundly. And for those patients, the question of medication timing becomes even more consequential because the baseline they are surging from is already elevated. George's eventual management included an evaluation for sleep apnea, which he had and which was treated, combined with a shift in his metoprolol timing to evening administration after discussion with his cardiologist. His morning symptoms resolved substantially over the following month. Now I want to address something directly because I know that some of you are thinking about it. If bedtime is better, why did my doctor tell me to take it in the morning? There are several reasons, and they are worth understanding rather than dismissing. The first reason is habit and adherence. Decades of prescribing practice established morning medication routines because they were easy to remember and easy to monitor. A patient who takes a pill with their morning coffee is more likely to take it consistently than one who has to remember it in the evening amid different routines. Adherence, taking the medication at all, was reasonably considered more important than the precise timing. For many patients, that calculus is still correct. The second reason is that for some medications and some patients, morning timing is still appropriate or preferred. Diuretics, water pills like hydrochlorothiazide or furosemide, are almost always better taken in the morning because their primary action increases urination. A diuretic taken at bedtime creates a miserable night of bathroom trips and disturbed sleep, which introduces its own cardiovascular risks. For diuretics, morning timing is the right answer. ACE inhibitors like lisinopril and ramipril, ARBs like losartan and valsartan, and calcium channel blockers like amlodipine are the medications where the bedtime or evening timing question is most actively discussed and most supported by evidence. Beta blockers are an intermediate case that requires individual discussion. The third reason is that the HYGEA trial and subsequent research, while significant, has not been without controversy. Some researchers have raised methodological questions. Not every cardiologist has changed their practice based on this evidence. Medicine moves carefully when established habits are involved, sometimes too carefully, but not without reason. What I want you to take away from all of this is not that you must immediately change when you take your pill. It is that the conversation about timing deserves to happen in your next appointment, with specific reference to your medication type, your blood pressure pattern over the day, your sleep quality, and your morning symptoms. If your doctor has never asked you whether your pressure is higher in the morning than in the afternoon, that is worth raising. If your doctor has never suggested home blood pressure monitoring at different times of day, that is worth asking about. Now let me tell you about Patricia, because her story brings in the piece I promised at the beginning, the morning timing mistake that is so common among seniors that I see it constantly. And that has nothing to do with the clock time on the pill bottle. Patricia was 64 years old, a retired dental hygienist from Arizona, fit, careful, and highly motivated to manage her blood pressure well. She took her medication every morning, she ate well, she exercised, and she monitored her blood pressure at home with an Omron Platinum blood pressure monitor, which she had purchased at Costco. She had noticed for months that her home morning readings seemed higher than her doctor's office readings, and she had mentioned this. But the response had been reassuring. White coat hypertension, her doctor suggested, the anxiety of a clinical setting raising the pressure. Patricia accepted that answer, but it nagged at her because the high readings were happening at home, where she was relaxed, not in the office. What Patricia was actually experiencing is called masked hypertension, and it is the opposite of white coat hypertension. It is the phenomenon where blood pressure is adequately controlled in the clinical setting but elevated at home, particularly in the morning. Masked hypertension is more common in older adults, more common in people with high cardiovascular risk factors, and more dangerous than white coat hypertension because it goes undetected and untreated while doing real damage in the hours it is elevated. And morning is the most common window in which masked hypertension operates, because that is when the surge is happening and when clinic readings, almost never taken before 9 in the morning, fail to capture it. The morning timing mistake Patricia was making was not about what clock time she swallowed her pill. It was that she was taking her blood pressure reading at 10 in the morning after her medication had already been working for 3 hours, showing her a controlled number and filing that as evidence that her mornings were fine. Her actual early morning window between waking at 6:30 and 8 in the morning before the medication peaked was never being captured. When I asked her to begin monitoring at 2 specific times, immediately upon waking before any activity or medication, and then again 1 hour after her usual waking time, the picture changed dramatically. Her immediately upon waking readings were regularly 10 to 25 points higher than her 10 o'clock readings. She was masking her own morning problem from herself with the timing of her measurements. Patricia's case led to a medication timing adjustment, a dose review, and a monitoring protocol that finally gave her and her doctor an accurate picture of what was happening in the most high-risk window of her day. But the starting point was recognizing that when you measure your blood pressure matters almost as much as when you take your medication. Here is what I want every person over 60 watching this to do this week. Take your blood pressure immediately upon waking, before you stand up from bed, before you drink coffee, before you take your medication. Write that number down, then take it again 1 hour later. Do this for 7 consecutive days. Bring those numbers to your next appointment and ask your doctor specifically about your morning blood pressure pattern. Ask whether your specific medication type at your specific dose is providing adequate coverage for your morning hours. Ask whether a timing adjustment has been considered for your case. If you are using a home blood pressure monitor, and if you are not, I would encourage you to get one, the Omron Platinum and the Omron Complete are both widely available at CVS, Walgreens, Walmart, Costco, and Amazon, and both are validated for accuracy and easy to use with clear displays for seniors. Whatever monitor you have, the technique matters as much as the device. Sit quietly for 5 minutes before measuring. Do not have caffeine in the hour before. Sit with your back supported and your feet flat on the floor. Take 2 readings and average them. Do not take a single reading and make decisions based on it. Now let me give you the clear framework I want you to carry from this conversation into your next doctor's appointment. First, understand that morning is the highest risk time of day for cardiovascular events in people with hypertension, and that the morning blood pressure surge is a real and documented phenomenon that peaks between 6 and 10 in the morning for most people. Second, understand that many commonly prescribed blood pressure medications may provide their strongest effect in the afternoon and their weakest effect in the morning when morning administration is used. This is a timing mismatch worth examining in your specific case. Third, understand that for many medication types, particularly ACE inhibitors like lisinopril and ramipril, ARBs like losartan and valsartan, and calcium channel blockers like amlodipine, evening or bedtime administration is supported by clinical evidence and has been associated with better cardiovascular outcomes in large trials. Diuretics are generally an exception and should remain on morning timing. Fourth, understand that poor sleep, which is extremely common in adults over 60, can amplify the morning surge and make timing even more consequential. If you have disrupted sleep, nocturia, symptoms of sleep apnea, or consistently poor sleep quality, that information belongs in your cardiovascular management conversation. Fifth, understand that when you measure your blood pressure at home is as important as how you measure it. Immediately upon waking readings, before medication, before caffeine, before significant activity, give you information about your morning exposure that no afternoon office reading can provide. Sixth, and most importantly, do not change when you take your medication on your own without your doctor's knowledge. This conversation is about information, not self-adjustment. The goal is to bring a more complete picture of your blood pressure pattern to the people managing your care, so that decisions about timing, dose, and medication type can be made with your full daily reality in view, rather than a partial snapshot captured in an afternoon clinic visit. I want to close with something that I think Richard would want me to say, the man I told you about at the beginning, the retired principal who had the stroke. When I spoke with Richard after his recovery, he said something that I have thought about many times since. He said, "I did everything they told me to do. I took my pill every day. I never missed. And I still almost died in my bed in the morning." And he was right. He had been compliant. He had been diligent. He had done what medicine asked of him. But medicine had not given him the complete picture. It had told him what to take and how much. It had not told him that when might matter just as much, or that the hours between 4 and 10 in the morning were the hours his medication should have been working hardest, and was instead working least. Richard did not do anything wrong. The system gave him incomplete information. That is what I am trying to correct today. Not fear, not confusion, completeness. Take your blood pressure in the morning before you do anything else. Write it down for a week. Bring those numbers to your doctor. Ask specifically whether the timing of your current medication has been considered in light of your morning pattern. Ask whether a bedtime or evening trial makes sense for your medication type. Ask what your doctor knows about your blood pressure during the hours you are asleep and just waking. Those questions, asked clearly and persistently, may be among the most important health conversations you have this year. Stay safe, stay informed, and I will see you in the next one.